Evelyn. All right, so for anybody who's watching this on YouTube, who's part of Stewart's, make sure you go to Vinyl and you fill out the 5-question quiz so we can get you your credit. All righty. So this week's education, this month's education rather, is on cardiology. So without further ado, pump it up with Zach, cardiology for EMTs and advanced EMTs. While this course is going to be directed more to EMTs and advanced EMTs, it's going to be applicable to all providers, paramedics and otherwise. All right, so everybody in the Zoom meeting and the YouTubers as well, you're getting a twofer. So we're doing kind of a 2-for-1 lesson because this first slide is a whole lesson on its own. I don't want this information to go in one ear and come out another. I want you to be able to retain it. So some optimal tools for long-term encoding of this information are on the screen right now. Obviously, there's rote rehearsal. You make notes and then you rehearse everything. You got chunking, which is putting things together in big chunks. Mnemonic devices like imagery. You have elaborative rehearsal, which is one of the most important things. That's relating new information to old information. And you have self-referencing, which is putting things in terms of your own life for yourself. And then we have the thing that's in red right now, which is spacing and repetition. So spacing and repetition is basically flashcards. You make flashcards, you review the flashcards until you have all of them right, then you set them aside for a little while, and then you review them again. So I encourage everybody in this training right now to write a couple notes. I don't want you to just look at the slide. I want you to be able to absorb the information, but at the same time, write a few notes and then translate those notes into flashcards so you can have some spaced repetition and review those flashcards every once in a while because cardiology is essential to our practice. We also have problem-solving methods. So in EMS and in medicine as a whole, we use all of these problem-solving methods, which are on the screen right now. So trial and error is utilized. Algorithms are things like the ACLS flowcharts, as well as our protocols. And then we have heuristics, which are rules of thumb. And then we have deductive reasoning, which is just clinical reasoning. And we have intuition, which is when a salty old paramedic gets on scene and they can deduce what's wrong with the patient right away. It's called we have such a large basis of patients that we see that we can be able to deduce what's going on before we can even do any reasoning. So heuristics is in red right now because throughout this training, I'm going to present some rules of thumb or heuristics that'll help guide you in the field as far as cardiology goes. All right. Any questions on this stuff? It's pretty straightforward, but I think it's important. So maybe take a couple notes, make some flashcards, and realize that I'm going to present some heuristics throughout this training. All right. So what are we going to go over? So we're going to go over the scope of practice. This is mostly going to be for EMTs and advanced EMTs, especially with the rhythms. We're going to have a basic understanding of cardiac anatomy and physiology. This will be a review for most people, but I hope I'll be able to present some new information for everybody. We're going to go over EKG basics, meaning what is an EKG, how is it obtained? Then we're going to go over lead placements. We're not going to just go over left-sided lead placements. We're going to go over normal left-sided, right-sided, V4R, and posterior, which are all important, and we're going to explain why. We're going to explain why when a 12 lead is necessary, and I'm going to give you a heuristic for that. We're going to go over what's normal versus what is not normal versus what is baseline for the patient. We're going to go over 12 lead interpretation, or rather 4 lead interpretation for advanced EMTs and those 7 rhythms that AEMTs are responsible for. We're going to go over what a STEMI is. We're going to go over the STEMI bypass protocol for lakes. And we're going to go over some more heuristics, which is when to place the pads on the patient and when to call for a paramedic. All righty. So first thing we're going to go over is our scope of practice. All right. So this is everybody's scope of practice. If I can get my laser pointer on the screen. Maybe, maybe not. There we go. Okay. So you can see EMTs and advanced EMTs have the same scope of practice as far as application of 12 leads and 4 leads, CPR, and defibrillation with an AED. But the difference is our interpretation here. And remember, it's 4 leads that we're interpreting, not 12 leads. So the rhythms that an advanced EMT can interpret are ventricular fibrillation, right? Ventricular tachycardia, asystole, and pulseless electrical activity, or PEA. We have these along with all of our sinus rhythms, right? Normal sinus rhythm, sinus tachycardia, and sinus bradycardia. And we'll go over all these rhythms later. So I just want you to understand that these are the 7 rhythms that AEMTs are responsible for on 4 leads. All right, so the last slide was adult scope of practice, okay? So we can interpret this on adults. Moving on here, this is pediatric scope of practice, okay? And you'll notice that that box is gone now. So we can't interpret rhythms on a 4 lead for pediatric patients. So in the state of New Hampshire, what classifies as a pediatric patient? Because traditionally a pediatric patient can be anywhere from someone up to 18 to 21. But in the state of New Hampshire, pediatric patients defined as any child who fits on a length-based resuscitation tape, like a Bracelet tape. So that ends up being a patient who's 36 kilograms, up to 36 kilograms, and up to 143 centimeters. Okay. So if we take national averages in the United States, that ends up being children roughly the age of 11 to 12. So as a rule of thumb, anybody under the age of 13 should be treated as a pediatric patient in the case of the scope of practice. And anybody over 18 can be treated as adult, but the endpoint is actually the resuscitation tape. So make sure if they fit on a resuscitation tape, then they're a pediatric patient. All right, any questions about the scope of practice? Fairly straightforward. And like I said, we'll go over the rhythms later. All right, here's a little shameless plug for power tools and Tempsys. So if you go into Tempsys and you look on the left side, or rather the right side of your screen, you're going to see this bar here. All right, and if you click vitals, this is a great way of entering vitals. I prefer this way rather than going in the other way to put the vitals in. So take a look at these if you're not familiar with the power tools. I think they're great. And then if you hit all, this box will come up, and you can see I have procedures circled. This is important because when we do anything cardiac, we need to put the procedure in Tempsys. Okay, this is important for CQI purposes and continuity in the when we evaluate what actually happened on scene. So if you type in the box cardiac, these are all our options for cardiac. Most of this stuff is going to timestamp by the monitor. Okay, like I'm sure all of you have already recognized this. When you apply leads on, it's going to timestamp that. When you get a 12 lead, it's going to timestamp that. But just realize we have other things that we can enter into Tempsys as procedures that are related to cardiac. And this is just not for cardiac procedures. This is for everything. So use the power tools, use the procedure tools, go in there and look at all the different procedures that are available to you and use the ones that are applicable all the time. All right. Any questions about Tempsys before we move on? Power tools or anything? All right, so we're going to go over some basic anatomy first and then some physiology. So I'm sure a lot of you want me to jump into the EKGs, the juicy stuff, and say, Zach, teach us how to read 4 leads, teach us how to look at these rhythms. But what differentiates a good paramedical provider, not even paramedical provider, a good medical provider versus a poor medical provider is a strong understanding in anatomy and physiology. So these first few slides that we're going to go over may be a review for some people, but it's extremely pertinent for our practice. Okay. You can understand 12 leads and 4 leads all you want, but if you don't understand basic anatomy and physiology, you're not going to be able to treat your patients efficiently. So this is the big stuff I want you to take away from this, the anatomy and physiology. All right. So basic anatomy. The heart's about the size of the owner's fist, and it sits right in the center of the chest in a place called the mediastinum. Okay, right in the center of the chest, dorsal to the sternum, but ventral to the spinal column. Because of the orientation of the heart, you can see on the screen here, it actually lies about 2/3 to the left side of the chest. This is why we do the 12 leads on the left side of the chest, and it's not centered, even though the heart itself is centered. It's just because of the orientation of it. Okay. The base, which is the top of the heart here, is located roughly at the 3rd rib, and the apex, which is the bottom of the heart here, is located just above the diaphragm.
What's this?
The heart is encased in a 2-layer sac called a pericardium. The heart itself has 3 layers of tissue: the endocardium, the myocardium, and the epicardium. The middle layer of tissue, the myocardium, is the tough part of the heart. That's the part of the heart that's responsible for contraction. The heart, as everybody knows, has 4 main chambers, right? The atria on the top and the ventricles on the bottom. The big thing to remember is the atria pump downwards, whereas the ventricles pump upwards. And when we go over electrophysiology, we'll see that the direction of the contraction of the atria and ventricles corresponds to the direction of the electrical flow. We also have to remember that atria pump in parallel, meaning they're not connected, but they pump at the same time. And independently, the ventricles pump in parallel at the same time. And we'll review the flow of the blood through the heart a little bit later here. So the 4 chambers of the heart are divided by this septum here, right down the middle of the heart. And the atria are divided by the ventricles from atrioventricular valves, atrioventricular, between the atria and ventricles. On the right side of the heart here, the AV valve is the tricuspid. And on the left side of the heart, our AV valve is the bicuspid, or the mitral valve. And an easy way to remember this, or at least the way that I use to remember this, is thinking of the amount of lobes we have in our lungs. Okay. On the right side, we have 3 lobes in the lung. So we have right side AV valve is tricuspid. And on the left side, we have only 2 lobes in the lung because, like I said, the heart's situated more on the left side. That's why we only have 2 lobes. This is the bicuspid, or mitral valve. So these valves separate the atria and the ventricles. We also have valves that separate the ventricles from the rest of the vasculature. These are the semilunar valves. These are called semilunar valves because of the shape of the valves. So these are super easy to remember the names because all it is where the blood's going. So the semilunar valve that connects the left ventricle to the aorta is the aortic valve. Okay, that's behind here. It's right down here. The semilunar valve that separates the right ventricle from the pulmonary arteries is the pulmonic artery. And we have to remember, arteries carry blood away from the heart. Veins carry blood towards the heart. Okay, we'll go over this again too. Arteries away, veins towards, regardless of if the blood is oxygenated or deoxygenated. All right, any questions about this basic anatomy of the heart before we move on? We're going to go over blood flow next. So if the question's on that, we're going to cover it. All right. All right, we got the basic anatomy down. How does blood flow through the heart? So we're going to go over, we're going to track like a single red blood cell through the heart. While we do this, we have to remember that the blood doesn't move in one path through the heart, right? Like I said, the atria will contract together into both ventricles, and the ventricles will contract in parallel. Okay, so it's not just this one dot moving through the heart. We actually have both atria contracting at the same time. All right, so blood flows in through the superior and inferior vena cava. So this is the veins, the big veins that bring the blood from the rest of the body into the heart, into the right side of the heart. Blood enters into the right atrium. Now remember, this is blue because that blood is deoxygenated. And why is it deoxygenated? Oxygenated because the body has utilized all of the oxygen, okay? So these red blood cells are going to travel through the heart and then into the lungs, grab some oxygen, and then go back out to the rest of the body. So right atrium contracts in atrial systole and goes through the atrioventricular valve, and on this side is the tricuspid, into the right ventricle. Then right ventricle contracts, right, at the same time as the left ventricle, and that blood goes through what carries blood away from the heart? Arteries. the pulmonary artery and into the lungs. And in the lungs, it interfaces at alveoli with the air that we breathe in, and we pick up oxygen. Okay, that's why it's red now. Then the blood flows through what carries blood into the heart? Veins, through the pulmonary veins into the left atria. Okay, and then during atrial again, that blood goes through the mitral or bicuspid valve into the left ventricle. Now, remember, the left side of the heart is far stronger than the right side of the heart. Why is that? Because the right ventricle is only pumping into the lungs. That's not a lot of vasculature compared to the left ventricle, which is pumping into the rest of the body. Okay, so it's all about vascular resistance. The more resistance we have, the stronger the heart has to be to pump against that. So that's why the right side, or rather the left side, is super important and stronger than the right side. So we got the blood in the left ventricle, and then you can guess what happens next. The aorta, which is an artery because it's carrying blood away. This is the aortic arch. Carries the blood out of the left ventricle into the rest of the body. And that completes the cycle and then starts again. Any questions about blood moving through the heart or the vasculature in general? Straightforward. I think it's basic anatomy terms that are probably what our people are recalling right now, mostly the valves. All right, what's the takeaway from all this anatomy? All right, I want you to know basic anatomy. Like I said, atria versus ventricles. Where's the blood flowing? Where do we have oxygen? Where do we not have oxygen? And then remember the valves, because this is important as well. A good way to remember the valves, besides the little lung anatomy I taught you, is LabRat. I like this as well, but this is for the atrioventricular valves. Okay, so LAB, L-A-B, left atrium bicuspid. Okay, or it's on the left side. We have two lobes in the lung, bicuspid. RAT, right atria tricuspid or mitral valve. Or it's on the right side. We have three lobes in the lung, tricuspid. So there's two ways to remember the valves, whichever works for you, utilize it, or both. Next thing is what we went over just briefly before. The left ventricle is the stronger part of the heart because it's pushing against more vasculature. It's pushing against the whole body versus just the lungs. I stressed this several times. Arteries carry blood away, whereas veins carry blood towards the heart. And this is regardless of if we have oxygen in the blood or not. Arteries away, veins towards. Here's a big one. LV dysfunction, left ventricle dysfunction. Okay. This is pulmonary edema versus peripheral edema. Okay. So if someone has left-sided dysfunction or left-sided heart failure, the blood will back up into the lungs. Think of it as a pipe. Like if we have a clog in a pipe, where's all that water going to back up? Before the clog, right? So the left side of the heart is fed by these pulmonary veins, blood coming in from the lungs. So if this left side of the heart isn't pumping well, we're going to have blood backing up into the lungs, and that pressure is going to push fluid into the alveoli. This causes pulmonary edema, okay? Left-sided heart failure causes pulmonary edema. And then conversely, right-sided dysfunction or right-sided heart failure, where is the right side of the heart getting blood from? Superior and inferior vena cava from the rest of the body, okay? So if we have dysfunction on the right side, that blood's going to back up in the rest of the body. And the legs, because they're so far down, they're fighting gravity, that's normally where you're going to see that peripheral edema, okay? Does that make sense to everybody? Any questions on that? Good. All right. We got the anatomy done with. Now we're going to go over the electrophysiology. What's going on electrically in the heart? Okay. This is my simplified version of cardiac electrical conduction. Okay. So the electrical activity of the heart is propagated from energy from these electrochemical processes. Okay. When you separate charges, so this is the inside of the cell, this is outside of the cell. When you separate charges, we want to be in a state of homeostasis, right? Those charges want to be dissipated. It wants to be even. We don't want to have a voltage across our cells. So when we have a charge difference across the barrier like this in a cell, that's energy, because those charges want to flow in and out and neutralize each other. This is how the heart contracts. It uses this form of energy. And the way it establishes this difference is movements of chemicals, most notably sodium, potassium, and calcium. That's why calcium channel blockers, it's part of this whole process. So the cells in the heart actually pump those particles back and forth and establish this gradient. So when the cardiac muscles are at rest, they're in this state. The inside of the cells are negatively charged, and the outside of the cells are positively charged. Like I said, this creates a potential difference. The cell wants to neutralize itself and have no charge across the cell membrane. So what happens is we have depolarization. Okay, the cell is polarized because it has a charge difference. And I'm sure you've heard this term before, depolarization. This is the action of the heart. This is when the charges flip. Those ions flow back and forth between the cell membrane because they're trying to neutralize each other, and the cell potential difference flips, okay? And this propagates throughout all the cells of the heart. This is what causes contraction. When a cell goes from a polarized state to a depolarized state, where that potential flips, the cells contract, okay? That's what causes the contraction of the heart. And then after that, as that other cells are contracting down the line, those cells that already contracted repolarize, okay? So there's little devices within the cell that pump the ions back so that it returns to a normal state here where it's negative on the inside and positive on the outside. And this is called repolarization. This gets the cells ready to contract again, okay? So the big takeaway I want from this is that depolarization is when the cell is depolarizing, which causes contraction. Repolarization is when the cells are relaxing again to get ready to depolarize. This is going to be important when we go over our EKGs. So that makes sense to everybody. Any questions? Okay, good. All right, so we understand what's happening basically on a cellular level. What's happening in the heart as a whole? Okay, I'm sure all these terms should be familiar with everybody. Okay, this is the electrical conduction of the heart. So the sinoatrial node, or the SA node, is located right here at the top of the left, or rather the right ventricle, okay? This is the natural pacemaker of the heart. This is the area of the heart that causes the normal sinus beat, the beat of 60 to 100 beats per minute, okay? That keeps the pace of the heart. So it initiates this depolarization. So what happens is the SA node depolarizes, right? That depolarization spreads through the atria next, and it goes through both atria in a wave. Think of it as a wave of depolarization. And as the atria depolarize downwards, they start to contract downwards into the ventricles, okay? Through these atrioventricular valves. That wave of depolarization then reaches the next point, which is called the AV node, or atrioventricular, between the atria and ventricles. At this point, there's a little delay in the electrical conduction of the heart. This conduction is going by really fast. You know how fast the heart beats? It's going by that many times. There's a short delay here. This allows the atria to contract completely so that we have all the blood ejected from the atria into the ventricles. So there's not blood pooling up in the atria. Why is this bad? Well, we'll see in terms of AFib why it's bad, because you could have clotting in the atria, right? So there's a pause at the AV node, and then the depolarization continues down the septum. Okay, this is important because the depolarization was moving through the muscles of the heart initially. Now it's moving through the septum, okay? And it's moving downwards, and it's not causing depolarization in the ventricles. Why is this important? If that depolarization moved downwards through the ventricles like this, the ventricles would contract downwards, right? But we know they don't do that. They contract upwards. So this is how the heart accomplishes downwards contraction of the atria with upwards contraction of the ventricles. So that electrical impulse travels down through what's called the bundle of His, and then it goes into the right and left bundle branches, and then into the Purkinje fibers and up, just like it did through the atria, but this time upwards rather than down, through the cardiac muscles, causing contraction of the ventricles. Okay, so the big thing besides the basic anatomy, SA node versus AV node, that I want you to take away from this is that that electrical impulse moves downwards through the atria, then through the septum, doesn't cause any contraction, and then upwards through the ventricles, causing upwards contraction. Does that make sense? Any questions about that? All right. So we understand basic anatomy. We understand physiology and what's going on electrically with the heart. Now we can get to understand EKGs. Here's the cool stuff now. All right. So first, right here, each small square, right, is 0.04 seconds. Okay. If you move the decimal point over 1, 2, 3 spaces, you get milliseconds, which is 40 milliseconds. Large boxes, right, are 0.2 seconds, or decimal point over 1, 2, 3, 200 milliseconds. Okay. This is important because we're going to be talking about length of certain waves and different features in an EKG. All right. So there's a lot of different waves in an EKG. Okay. And at the level of an EMT or an advanced EMT, I'm going to tell you exactly what I want you to understand and focus on, okay? Because we got all this excess stuff like U waves, and we can have delta waves and all this other stuff. Don't get caught up in all that minutia. I'm going to tell you exactly what waves I want you to be looking out for, at least at the level of an EMT and advanced EMT. For paramedics and above, this will be reviewed for you, hopefully. All right, so the first thing we see is the first positive deflection from the isoelectric line going upwards, right? Positive deflection. This is the P wave, okay? The P wave corresponds to atrial depolarization. So if we go back and we remember, depolarization equals contraction, right? Depolarization is that flow of electricity through the heart causing contraction. That P wave symbolizes atrial depolarization, that electric flow, and the atria contracting, okay? Then we have this little pause. Why do we have that pause? Remember I said it pauses so that the atria can eject completely in the ventricles. That's why we have this pause. But before we move on, what does a normal P wave look like? All right, it should be upright. It should be symmetrical, right? It's the same on both sides. If you draw a line down, both sides look the same. It should be upright and symmetrical in leads 1 and 2. It will be inverted in AVR in a normal EKG. Okay. And you should have one P wave for every QRS complex. Okay. No QRS complex should be missing a P wave, and there should be no extra P waves. All right. Makes sense? Upright, symmetrical, no extra P's, one for every QRS. All right. What's the next important wave? Well, you got a couple waves in this complex, but we're going to take it as one full complex. This is the QRS complex. Okay, there's a lot of stuff going on in this QRS complex, but at its core, what's going on is ventricular depolarization and atrial repolarization. Okay, remember, depolarization, contraction of the ventricles, and then atrial repolarization, the atria are getting ready to contract again. Okay, that's why it's this large complex with waves going in multiple directions, because there's a lot of things going on electrically. Okay, so that's all I really want you to understand about this. This is the perfusing beat of the heart, because this is when the ventricles are contracting. Okay, that's what this massive R wave is. All right, moving on. The next wave we see is the T wave. Okay, the T wave corresponds to ventricular repolarization. Okay, so the ventricles contracted in our QRS complex or depolarized, and now they're repolarizing, getting ready to contract again in this T wave, okay? Unlike the P wave, this T wave is not symmetrical, okay? This is normal. But it should be upright in all leads except for AVR and V1, okay? Good? All right, those are all the waves that are important. P, QRS complex, and then T wave. All right, corresponds to everything that's going on electrically with the heart that we talked about earlier. All right, we went over our waves. Now let's go over the other important characteristics on EKG. So the first thing I want to look at is the PR interval, okay? The PR interval is the start of the P wave, okay? Right when you start to see that positive deflection, up to the start of the QRS complex, okay? You're not always going to see a pretty Q wave like this, all right? It might butt up right against the R wave, or the Q wave might not be very evident, but it's start of the P to the start of the QRS, okay? In a normal rhythm, this should be 120 to 200 milliseconds, which corresponds to 0.12 or 0.2 seconds or 3 to 5 small boxes. I suggest you remember it as 3 to 5 small squares. That's the easiest way to remember it. But understand the length of these squares, okay? The next is down here. This is the QRS duration, right? The duration of the QRS complex, okay? In a normal rhythm, the QRS duration should be roughly 100 milliseconds or 0.1 seconds, which is 3 small boxes, okay? Roughly. I believe it's the last thing, yeah. Okay, the last thing I want you to remember is and you guessed it, the ST segment. We all know why this is important. What is the ST segment, first of all? Okay, the ST segment is the end of the QRS complex, which is called the J point, okay? So when the QRS complex returns to the isoelectric line, or should. All the way up to the start of the T wave, okay? This ST segment should be in line with the isoelectric line, which is this nice red line that I drew in for you. When it is not, what do we have? ST segment elevation or depression, right? That's significant for STEMIs, and we'll be talking about that later. So end of the QRS complex to the start of the T wave, this should be flat right on the isoelectric line. Any questions about the 1, 2, 3 waves and the 1, 2, 3 segments that I want you to remember? Okay. All right. So we understand what's going on electrically with the heart. We understand what we're seeing in an EKG as far as the waves, how it corresponds to contraction and depolarization of the heart. The next step is to understand what the EKG is actually seeing. Okay, this is Einthoven's triangle. So William Einthoven was a Dutch physician who invented the EKG, which was back in 1893. He won a Nobel Prize later in the early 1900s for it, 1924. So EKGs, I want you to remember, are all about the positive charge, okay? It's all about the positive charge. When we have an EKG, let me get my pointer back. Each of these electrodes that we're putting on the body correspond to either positive or negative, okay? And that can change depending on the lead that we're looking at, okay? You can see the left arm's positive here in lead 1, and the left arm is negative here in lead 3, okay? This is why we have more than 10 views, even though we have 10 electrodes, because these electrodes can change depending on the view. So what these are actually looking at is if you think of yourself as a little guy here, or an eye, standing at the positive electrode, depending on the lead, and looking towards the negative electrode, you're watching a flow of electricity, right? That depolarization of the heart, which is causing the contraction. If that depolarization, which is a wave of positive charge moving through the heart, is traveling towards you, towards that positive electrode, you're going to see a positive deflection from the isoelectric line. So when we see our EKGs and we have that positive deflection, that's because that's a wave of positive charge moving towards that positive electrode. And as you can see here, each view, we see the same basic waves, but with different amplitudes, right? They have different heights. Why is that? That's because the vector or the angle at which we're looking at the heart is different, right? We're looking at it this way here. We're looking at it this way in lead 2, and we're looking at it this way in lead 3. Okay, so since we have a different angle at the heart, that wave of positive, of depolarization, positive charge, looks differently at different angles, okay? Because if it's coming right at you from one angle and you're looking at it from the side, it's going to look smaller from the side, okay? This is important because remember how that wave of depolarization goes down through the ventricle, or down through the atria, through the septum, and then back up through the ventricles, right? That's why we're seeing these different waveforms, because the direction changes. That probably confused everybody. Does anybody have any questions on that? Just remember, it's a wave of positive charge, and each lead, you're standing at the positive electrode and you're looking at the other electrode. This is important because when we look at 12 leads, we can see different angles of the hearts based on the vector between the electrodes. Okay, so that's what we're seeing in an EKG. All right, we went over what we saw in EKG. Now let's go over the basics. Lead placement. Okay, first, limb leads. All right. Every provider should be familiar with the monitors. If you're not, then we should do a little in-service. Just ask me or someone else and we can go over it, especially with 12-lead acquisition and transmitting to hospitals. Limb leads should be on the limbs, okay? That's why they're called limb leads. Limb leads should be out on the limbs. They should avoid bony prominences. They should be on the meaty parts of the body, okay? The best places for the arm leads are either the wrists or the anterior deltoids, the front of the deltoids. You can also go lateral too, but the front's the best placement. The best place for the leg leads are right above the ankles, medially, or on the quadriceps, okay? Avoiding bones. So the important thing to remember is if you place leads out on the wrists, we have to keep the vectors the same. These monitors are calibrated for certain distances between electrodes. So if we put the electrodes out on the wrist, you preferentially need to get the electrodes out on the legs, okay, down on the ankles. If we put the leads closer to the body here on the anterior deltoids, we should be placing the leg leads on the quadriceps, okay? And I'm sure all of you have seen the placements on the body where we put it on the torso, right? Okay, on the chest and the abdomen. That's acceptable, but not for 12-lead acquisition, all right? The best place to get a 12 lead is placing these limb leads out on the limbs, okay? At times where it's acceptable to place them on the torso would be for, first of all, speed and acquisition. Sometimes it's, especially in the wintertime, it's hard to strip clothes off and get the leads out. We can put it on the torso in those cases. When we have fractures out on the limbs, we don't want to be putting the leads on fractures or near fractures. When there's an amputation, that's an obvious one. And if there's major artifact and we can't relieve that artifact by any other means, then sometimes placing the leads more towards the midline of the body on the torso will help relieve some of that, reduce some of that artifact. Otherwise, when we're getting 12 leads, limb leads belong in the limbs, okay? If we do put the limb leads on the torso in a 12 lead, document that on the 12 lead, okay? Questions about limb leads? Straightforward. When you place the limb leads on there, make sure you go back and make sure the right arm's on the right arm, the left arm's on the right arm, the left arm's on the left arm. It's easy to mix them up, and that'll really change our 12 leads. All right. Let's go over the anatomy before we go over the 12 lead placement. All right. So we have the sternal notch right here, okay? And then we have the sternum, okay? The ribs are here, and in between the ribs are the intercostal space. All right, we all know this. The line that splits right down the middle of the clavicle is called the midclavicular line. Who would have guessed it? The line that cuts us, all right, this way, right through the armpit, that's called the mid-axillary line. And then the line in between the midclavicular line and mid-axillary line is the anterior axillary line, okay? These are the most important anatomical lines for 12-lead placement. Notice nipple's not labeled on here, okay? The nipple is not an anatomical landmark for 12-lead acquisition, okay? It's going to be different on every patient. It's too superficial. Never use the nipple, all right? Use these lines, okay? And also understand this is the clavicle here, okay? At the end of the clavicle is all called the AC joint, right? This doesn't go all the way out to the end of the deltoid, okay? It doesn't go all the way out here. It stops more towards midline. So your midclavicular line is actually a little bit more towards midline than you would think, okay? So just realize that. All right. Any questions on that anatomy? Remember these lines, okay? Because next we're going to go over placement. So this is a normal left-sided 12-lead, okay? So some people do placements differently, and I'm going to suggest my way of placing the leads. What I do is I place 1, 2, then I place 4 because this has an easy anatomical landmark. Then I place 6, and then I fill in the gap with 3 and 5, okay? So let's go over the precise placements for these. When you're placing a 12 lead, don't lazily slap on the leads and assume that you have the correct anatomical placement. Palpate, okay? Palpate for these intercostal spaces. They're easy to palpate. Start at the sternal notch, palpate down, 1, 2, 3, 4, okay? The V1 and V2 leads should be in the 4th intercostal space. Obviously, 1 goes just right of the sternum and 2 goes just left of the sternum. So these are the first 2 leads that we're going to be putting on, okay? Then we palpate down 1 intercostal space, okay, into the 5th intercostal space. And we find the midclavicular line, recognizing that the AC joint is here and that the clavicle doesn't go all the way to the edge of the deltoid. And then we're going to place that V4 in the midclavicular line in the 5th intercostal space, okay? Then we're going to find our mid-axillary line, and we're going to place V6 on the same level of V4. When you place V6 and the patient's sitting on the stretcher, most of the times you're going to have to get in there and manipulate the arm, okay? Or else you're going to place 2 towards the front of the body than it should be. Most V6 placements I see don't get dorsal enough, okay? So actually go and find that mid-axillary line. And then once you have these leads, it's easy filling in, okay? Because V4 goes in between 2 and 4 on a straight line, and V5 goes in between 4 and 6 on that same level, okay? Remember these anatomical placements. Don't forget which intercostal space it goes in and palpate every time we place, okay? Any questions? Good. When do we do these? When is a 12 lead necessary? All right. So the heuristic I'm going to give you for this is every time you're on scene, ask yourself, can the cardiovascular system be involved in this patient's chief complaint or symptoms? If the answer is yes, acquire 12 lead, okay? We want to think critically about our patients. So if you get on scene, you ask yourself this every time, can the cardiovascular system be implicated in this patient? Take a 12 lead. You won't be wrong. When in doubt, take a 12 lead. Otherwise, most of these are right out of our protocols, okay? Obviously, ACS, right? We're going to be taking a 12 lead. Let me get my laser pointer again. Maybe. There we go. Dysrhythmias, that's straightforward. CVA, This one's not so straightforward. Why are we taking a 12 lead on CVA? Okay, if we think about what could have caused the stroke, we'll realize why, right? Because the stroke could be caused by a clot, and that clot could have originated in the heart, right? And the patient may be in some rhythm, such as uncontrolled AFib. That's why we're doing 12 leads for this. Shortness of breath and dyspnea. That's an obvious one. PEs might be implicated. CHF, again, obvious. Hypotension. We need to find the source of the hypotension. The heart could be implicated. Syncope. Most syncope we don't know the reason for, but the patient could have a dysrhythmia and that could be causing it. Altered mental status. Obviously, the cardiovascular system can be implicated in that. When we get ROSC of our patients after resuscitation, we want to see what rhythm they're in. And
What's up?
Abdominal pain, right? What runs through the abdomen?
They're
A lot of
talking
vasculature.
over. They're
So
paging.
this
They're
is
paging
important to get
right
a
now.
12 lead for
I was about to do
abdominal
the
pain.
same thing, but that's what they.
And then this is for Nick here, and at the bottom, non-traumatic back pain. So this goes along with our ACS patients, right? ACS is not just crushing substernal chest pain. ACS patients, especially women, can present with different symptoms such as arm pain, jaw pain, pain between the shoulder blades, and even abdominal pain, right? We got that right here. So also non-traumatic back pain. Take a 12 lead. We strive for getting a 12 lead in under 10 minutes on scene to 12 lead time in under 10 minutes for patients who we are dispatched for chest pain or ACS. Okay. I understand that some patients will complain about a bunch of stuff, and then halfway through your assessment will complain about chest pain. It's not those type of patients we're talking about. Once they complain about chest pain, get to 12 lead right away. But the on-scene to 12 lead time in less than 10 minutes, we're talking about these patients where we get dispatched for ACS or ACS-like symptoms. Okay? Questions about when we need to take a 12 lead. Just ask yourself if the heart and the cardiovascular system can be involved. If it can, take a 12 lead. All right. So that was our normal left-sided 12 lead. That's what we do most of the time. Now let's go over these variations. V4R. Okay. So if you look at the heart, remember it sits right in the middle of the chest, but most of it is actually to the left side. So therefore, the only lead, or rather the only electrode here that we're seeing the right side of the heart with is V1. Okay. All the other ones look at the left side of the heart. This is good because the left side of the heart's important because it's the strong one, right? It's pumping to the rest of the body. But the right side of the heart is also important. And the only lead we have looking at is V1. So what V4R maneuver does is allow us to see the right ventricle a little better, okay? So in order to do V4R, it's a simple maneuver. All we do is we take our normal V4 lead and we move it, we mirror it, right, across that sagittal plane that splits the body this way and place it onto the right side. 1, 2, 3, 4, 5. We're still in the fifth intercostal space, and we're still on that midclavicular line, okay? It's just on the right side. When you acquire a V4R, when that strip prints out, write V4R on it right away so that we can differentiate that from our normal left-sided 12 leads. So when we go into the hospital, the doc can see it, or other providers. So mirrored across placement. All right. So we're going to go over V4R and right set a little bit and why we do it. But before we do that, this is a full right-sided 12 lead. Okay. We can do this as well. Again, we just mirrored across that sagittal plane. Remember, see that V1, where'd my laser pointer go? V1 and V2 are flipped. Okay. Remember this? If they're in their normal placements, it's not too consequential, but we should try to flip these when we do a full right-sided 12 lead, okay? Other than that, all the leads are in the same placement, just on the right side of the chest, so we don't need to go over those placements again, okay? This is good, but V4R is sufficient. Why? Because we see one good view of the right side, okay? And it's faster, because sometimes we're doing more important things than moving leads across the patient's chest. So if you only have time, V4R is the most important thing, okay? All right, so this is what you see when a 12 lead prints out. Okay, the paramedics who are watching this video or in the Zoom meeting will be very familiar with this. So before we go over this, I'm going to say V4R, based on some studies, has a sensitivity of 88%. Okay, that means it can correctly identify disease in 88% of the time.
I mean, they need keys.
Has a specificity of 78%.
Told you I didn't have it.
Which means it can rule out disease 78% of the time. And it has a diagnostic accuracy of 83%. Okay, so it has 83% accuracy in diagnosing a right-sided involved MI. Okay, that's significant. So V4R is helpful and important. When is right side involvement most common? Okay, right-sided infarcts has about a 40% incidence in all MIs. So in all heart attacks you see, about 40% of them will have right-sided involvement. The rest are just isolated left-sided involvement. Okay. Who are we going to see mostly with right-sided involvement? Well, those patients, get my laser pointer again. Those patients most likely to have right-sided involvement are patients who are having an inferior wall MI. Okay. So it's elevation in our inferior leads. These are the most common patients to have right-sided involvement. Okay. Right side MIs with right-side involvement, we have to remember, have are very preload sensitive, meaning they have a high possibility of hypotension with nitrate administration. So when we have STEMIs and we see this inferior involvement, we have to think the right side of the heart might be involved. And when we give nitro, we have to be aware of the fact that the pressure might tank significantly. Okay. At the EMT and advanced EMT level, obviously, you're going to have a paramedic when all this is happening, unless you're running an advanced EMT truck and you're the first on scene. So I want you to all be aware of the fact that when you see a STEMI in these red boxes, you have a possibility of right-side involvement and a possibility of profound hypotension with nitrate administration, right? This is why we need to have an IV established before we give sublingual nitro to these patients, all STEMI patients, but these patients in particular, okay? So a good heuristic to know when to do a V4R is for these type of patients who have these inferior infarcts, okay? As long as bandwidth allows to do that V4R, do a V4R in these patients, okay? The other patients that we should be doing a V4R is patients who are having chest pain or have a great story for ACS, but present with a normal left-sided 12 lead, right? So this normal left-sided 12 lead, or the left-sided 12 lead is normal, but the patient has a great story for a heart attack. So we move that lead over to the right side of the chest because maybe there's stuff going on the right side that we can't see. All right, and we're going to go over this more for posterior as well, okay? Posterior 12 leads. All right, we got our normal left side, we got our right side, we got our V4R, now we got our posterior. All right, posterior infarcts are more uncommon, even more uncommon than right-sided. They happen in about 15 to 20% of STEMIs, okay? And they mostly accompany inferior, bottom of the heart, and lateral infarcts, okay? Isolated posterior infarcts, so heart attacks on the backside of the heart alone, are very uncommon. They happen in only about 3 to 11% of STEMIs. All right, how do we do a posterior 12 lead? All right, well, it's quite simple. We take, so these are our normal 15 leads when we have V7, V8, V9. But what we do is we actually take V4 through 6, V4, 5, and 6, and that becomes 7, 8, and 9. Okay, so this is 4, 5, and 6, and we leave the other leads alone, okay? Because we're not capable of doing a full 15 lead EKG with our monitors. All right, so what are the anatomical landmarks that we're looking for these posterior EKGs? They may seem rather daunting, but they're actually very simple. So I suggest we place V8. So our V5, okay? We find the tip of the scapula. The scapula is the shoulder blade. So we find the tip of the scapula on the left side of the back, and we put our V8 there, which is our V5, okay? And then the other leads are simple, right? We just put our V7 in the left posterior axillary line, okay? So right lateral to V8, but medial, more midline to the mid-axillary line. And then we put our V9, which is our V6, in between the spinal column. Make sure it's not on the spine, right? We avoid bony promises. Between the spinal column and V8. Okay, simple. Find the scapula, put it at the base, fill in the other leads. And that's our 4, 5, 6 becomes 7, 8, 9. Again, when we print these out and they're not normal left-sided EKGs, we have to write on the strip that this is a posterior. Okay, so what type of patients do we do posterior 12 leads on? Well, we want to do it on patients who have depression in V1 and 2. Okay, V1 and 2 is looking at the septum, right in the middle of the heart, right? If we see depression, that's a reciprocal change possibly of elevation on the back. So we look at the back of the heart. Also, if we see some elevation in V5 and 6, right, the leads that are moving dorsally, moving towards the back of the heart, if we see some elevation in there, we should be doing a posterior 12 lead as well, because that could indicate that there's more elevation along the back of the heart, okay? And then along with that, as well as the patients I was talking about doing V4R on, we should be doing this for patients who present with a good story, but have a normal left-sided 12 lead. So patients with good stories, normal left-sided 12 lead, we want to be looking at the whole heart. So we want to be doing that V4R and a posterior, okay? See if we're missing any infarct. Does that make sense to everybody when we want to be taking these alternative EKGs and as well as the placement? Good. Already went over this. Okay. Depression in these leads, elevation coming around the back. Good story. All right. We went over placement. Now we're going to go over some housekeeping stuff. Normal versus not normal versus baseline. Okay. This applies to everything, not just cardiac. Normal is normal sinus rhythm. When you document and you say normal, and you're talking about EKGs, that means normal sinus rhythm. Not normal is anything that is not normal sinus rhythm, okay? Baseline, or the patient's native rhythm, is what the patient normally has, okay? If the native rhythm or the patient's baseline is not normal sinus rhythm, that rhythm's not normal, okay? It's normal for the patient. So this is a document problem. So never say normal unless it's normal sinus rhythm. Use the terms baseline or native rhythm when you're describing the patient who doesn't have normal sinus rhythm as their baseline, okay? And this is the same thing with everything else, including mental status. Never say normal unless the patient is normal. Use these terms instead, baseline, okay? Or the patient's normal. Just avoid normal in general. All right, makes sense to everybody? Good. All right, let's read some 4 leads. Okay. How do we interpret strips? All right. First of all, we have to remember that we're not reading these strips away from the patient, right? We're looking at the monitor, but we're also looking at the patient. So when we read our 4 leads as advanced EMTs, okay, EMTs can't do this, and we're not talking about 12 leads. Typical analysis of strips will use what's called the EKG rule of 4s, okay? And you'll see it here on the left side of the screen. We do the 4 initial features, then we look at 4 waves, and then we look at the 4 intervals. You'll notice we didn't actually go over all of these waves. Like here's your U wave, here's your QT interval. I went over only a few of them purposefully because I have a modified version of this for advanced EMTs, okay, for interpretation of 4 leads. So the rule of 4s for advanced EMTs that I'm suggesting is 1, history. 2, we look at rate. Next, we look at the rhythm. Last, we look at waves and intervals. Okay? So this is the big thing here, okay? Whenever you read a strip, We're not ripping the strip off and putting it in front of our faces right away. We have to have collected a sample history, okay? We have to understand the patient's native rhythm, their history, the meds that they're taking before we can jump into this and analyze the strip, okay? Because if you look at the strip and the patient's in AFib and you're thinking, oh, this is acute AFib, and you didn't gather a history and that's the patient's native rhythm, that's a problem, okay? So number one is always history. Number two, rate. Number three, rhythm. Number four, waves and intervals, okay? Any questions about the rule fours? Just remember, take a history first. We already went over this. What are the 7 rhythms that AEMTs can interpret on a 4-lead, not a 12-lead? We have our sinus rhythm. So sinus rhythm or normal sinus rhythm, which is sinus rhythm 60 to 100 beats, right? Then we have sinus bradycardia, sinus tachycardia, ventricular fibrillation, ventricular tachycardia, asystole, and pulseless electrical activity. Why are these next to these two? Because these are possibly responsive to defibrillation by an AED when you're doing CPR, okay? Asystole is not shockable. Pulseless electrical activity is not shockable. And when we see these two, we light them up in AED mode, okay? The monitor's interpreting this rhythm while you're doing CPR. But, and you'll see later, we can see some of these rhythms on conscious patients. All right, first one, easy one, normal sinus rhythm. All right, you can see all the normal waves that we already went over. P, QRS complex, and then the T wave, okay? This rhythm's generated by the SA node, right? It's at a rate, okay, history, say no history of arrhythmia. Next, we look at the rate. The rate is 60 to 100 beats per minute in normal sinus rhythm. It's regular, right? The R waves line up. The P waves are present. There's no extra P waves. There's a P for every QRS, right? All the stuff we already went over. The P waves are upright and the leads that are upright, which are 1 and 2. Okay. And all our intervals are fine. And the ST segment's not elevated. Okay. Normal sinus rhythm. Any questions on normal sinus rhythm? This is an easy one. Sinus brady. Exactly like normal sinus rhythm, but slower. Okay. When we see a patient in sinus brady and they're symptomatic, right? They have altered mental status, they have hypotension, they have other signs. We need to call for a paramedic when we're at the advanced EMT and EMT level. We're going to do routine patient care, right? If they have a low sat, we're going to put them on oxygen. We're going to place the pads, right? Okay. We're going to place the pads such that they're ready for when the paramedic gets there. Okay, because the paramedic might need to pace this rhythm. And we're going to go over this a little bit later too about pad placement. We're going to get IV access. We're going to do a 12 lead, and we're not going to delay transport. That's the biggest thing, okay? We're calling for a paramedic, but we're not delaying transport, okay? We have the tools at the advanced EMT level to take care of these patients, all right? We just can't pace them. We can't give them meds. But we can get them in the ambulance. We can get the pads on them. We can get IVs in them. We can get a 12 lead, and we can get on the road fast and get to a paramedic or definitive care at a hospital if it's closer, okay? Never delay transport, all right? And we'll go over pad placement in a little bit here. Sinus tachycardia, same thing as normal sinus, but faster, okay? Sinus tachycardia occurs when it is over 100 beats per minute, okay? You have to realize that we might not actually see individual P waves. This might have what's called a camel's hump where the T wave and the P wave are obscured into one wave. This is moving towards SVT territory, especially when we get up over 150 beats per minute, okay? When we start seeing that, we should be concerned. If just like in sinus in sinus bradycardia, if we have a patient who's in profound tachycardia and they're symptomatic, we're doing all the same stuff. Okay, we're calling for a paramedic, we're getting IV access, and we're getting a 12 lead, and we're not delaying transport. Okay, any questions about the sinus rhythms? Good, you guys are great. Now we get on to the fun stuff. VTAC, ventricular tachycardia. Okay. Ventricular tachycardia is caused by improper firing in the ventricles, okay? This rhythm is typically pulseless, okay? But you can have a pulse with this rhythm. It's rare, but you can, especially in young people. Some young people will go into VTAC suddenly for unknown causes and then go back into normal sinus rhythm. But it's uncommon. But realize that you can see ventricular tachycardia in a conscious patient, okay?
The fuck?
Ventricular tachycardia, you will see in about 7% of cardiac arrests. But patients in VTAC and cardiac arrest have a 45% survival rate. Okay. Why is that significant? That's a big number. Why is that significant? This is why in cardiac arrest, we place the pads quickly. This is why we emphasize quick pad placement, okay, and then initiation of CPR. Because if we find this patient in ventricular tachycardia, could be very responsive to cardioversion, okay? So it's very important to get those 12 leads on, or the pads on, really quick. If the patient is stable and conscious and they're in this rhythm, we want to take a 12 lead because, courtesy of the paramedics here, this may actually be rapid AFib with a left bundle branch block, okay? If you see this in lead 2 on your 4 lead, and the patient's conscious and they're stable and they don't have any profound hypotension or altered mental status, do a 12 lead, okay? Because it might be AFib with a left bundle. There you go. Rapid AFib with a left bundle branch block, okay? But like I said, very uncommon. You're not often going to see conscious patients with this rhythm. But if you see something like this and you start freaking out and think of the patients in VTAC, but they seem normal, and you have time to take a 12 lead, take a 12 lead, okay? If they're unstable, we get the pads on fast because it's responsive to defibrillation, right? We get the pads on, we call for a paramedic, we do everything we do that I said for sinus Brady, and we do not delay transport, okay? These patients, if they're unstable, can rapidly go into ventricular fibrillation and code, okay? And obviously this is regular with a wide QRS complex, okay? Oh, did I lose my video?
No, you're good. I got you, Zach.
Can you still see me?
I can't see you, but I can see the screen.
Okay, I think I lost my video. I'll fix it in a bit. All right. You see the slide change? Can everybody see the new slide?
Yeah, you got a 12 lead up there, Zach.
Okay, thank you. All right. What did we just go over? We went over ventricular tachycardia, right? Okay, there you go. Boom, light them up. So if you are just taking a 4 lead, what are you going to see? You're going to see 1, 2, and 3 here, usually, depending on how the monitor's set up, right? If the patient's stable, right, again, we're going to do a 12 lead. So we did this 12 lead, and we see VTAC in all the leads. This is VTAC. All right, if we're at the EMT or advanced EMT level, we're going to do basic maneuvers. We're going to get the pads on a patient. We're going to get an IV. We're not going to delay transport, okay? And we're going to intercept with the paramedic if we can, because this patient needs defibrillation or medical intervention, okay? Ventricular fibrillation. This is not a good rhythm. You will not see a patient with a pulse with this rhythm. It's very disorganized. It doesn't cause a perfusible beat. It's random. It's chaotic electrical activity, okay? You will only see this rhythm in patients who have coded, all right? Our treatment for this is defibrillation by AED and cardiac arrest. And here is VFib on a 12 lead. All right, and now we have asystole, easy. Asystole is our classic flatline rhythm. This is no electrical activity. These patients will not have a pulse, and this is not shockable, okay? Here's asystole on a 12 lead. Lastly, the last rhythm in the AEMT scope of practice that we can analyze on a 4-lead is pulseless electrical activity, or PEA. PEA is any rhythm that is not VTAC, not VFib, and not asystole that does not produce a palpable carotid pulse. Okay? So if you see some organized electrical activity on your pad view or your 12-lead, but you don't have a palpable carotid pulse, that is PEA. What do you do when you see PEA? You continue CPR. This is not a shockable rhythm. Okay, so don't get hyped up when we see these what look like organized electrical rhythms when we are performing CPR. And we have to remember, when we see this on the monitor, we're not stopping compressions. Okay, we're not staring at the monitor while we're doing our 2 minutes of compressions. If we start to see this on the monitor, we continue our compressions, and then we see if we have a palpable carotid pulse at the next rhythm check. If we do not have one, we continue CPR. Okay, that's important. We don't want to stop CPR when we see this stuff. The pulseless electrical activity is rather uncommon. It happens in about 12% of out of hospital cardiac arrest in which the rhythm is not shockable. The vast majority of non-shockable rhythms is asystole. Okay. This is AFib. AEMTs, this is not a rhythm you can interpret on a 4-lead, but it is a rhythm that you should be able to recognize. Okay. Legally, in your scope of practice, you cannot interpret this, but you should be able to recognize. Okay. This rhythm is caused by the AV node being bombarded by electrical signals, and the atria are actually quivering. Okay. What is the iconic presentation of atrial fibrillation? Well, these patients will have an irregular rate, and there will be no P waves present. Okay. If I can get my laser pointer out here again. There it is. Okay. So we can see this is irregular, and we don't see any P waves. We have this just chaotic baseline here. Okay. So irregular rhythms without P waves, likely AFib. What do we do for these patients? We do routine patient care again. If this rhythm is uncontrolled classically is over 100 beats per minute. Oops. But if this rhythm is uncontrolled and we have symptoms, we're going to do the same thing as all the other stuff. We're gonna get IV access. We're going to call for a paramedic. We're going to give 12-lead, and we're not going to delay transport. All right. So again, you cannot interpret this, but you should be able to recognize this rhythm. And again, Evelyn just put prior history up. Remember when we do a rule of 4s, when we're analyzing our 4 leads, the first thing, what is number 1, is history, right? We're gathering a history. Does the patient have a history of AFib? Okay. Are they on medications for AFib? All right. Are they on anticoagulation medications? Here's a 12-lead of AFib. Okay. We can see it's not regular, and there's no P waves. Okay, again, we can't interpret these 12 leads, but this is a real world example of what you'll see AFib in the field. All right, this is not AFib. Okay, I'm not trying to trick you here. Look at this for a second, and what do you see? Hopefully it jumps out at you right away. I'm going to give you a couple seconds just to take a peek at it, and then I'm going to advance the slide. Look at that. Okay, so this is the same patient. If you look at the timestamps here, this is 1402. Last one is 1302. I'm going to flip back and forth. These are 12 leads on the same patient an hour apart. Okay, we can see the progression of the ST elevation here and depression. Okay, All of you, regardless of your level, should be able to recognize that. Okay. You can't necessarily interpret this, and you can't say that the patient's having a STEMI unless the printout says STEMI when you're at the advanced EMT and AEMT level. But you should be able to see this on the monitor and recognize it right away. Okay. And this next slide here, I have the ST segment in green and the isoelectric line in blue. So you can see the significant elevation, and you can see the depression here and leads to an AVF. Okay, so this is a significant 12 lead. So what is a STEMI? STEMI is a myocardial infarction. It's what you think of as a classic heart attack, and it's caused by ischemia or blocked blood flow in the heart, okay, which can cause tissue death. So STEMI is an acronym for ST elevation myocardial infarction, okay? And then this is just review. It should be review for most of you. ST elevation, remember, is the end of the QRS complex to the start of the T wave. This is your J point, which is the end of the QRS complex. And here's your ST segment. This is elevated from the isoelectric line. Here on the normal 12 lead, it's right on the isoelectric line. Here on the 12 lead, it's depressed. Okay, so this is ST elevation. This is ST depression. Are there any questions about STEMIs and ST elevation versus depression? Okay. All right. When we see this, what do we do? All right. On this side of the lake, this is the LRGH STEMI bypass protocol. Okay. At the advanced EMT and EMT level, we're looking at a 12 lead printout. And if it'll say something like this, I'll have 3 stars and I'll say acute MI or something of the sort. When we see this on the monitor, the patient needs to go to a PCI center. Okay. They need to have cardiac intervention, likely a cath. Where are our PCI centers? So on this side, we have Concord Hospital. And on the other side, we have Wentworth Douglas or Portsmouth. And the people who work in Wolfboro more often can comment on that side of the lake because I'm not super familiar with that process. But what do we do when we see this? Okay, when we're at the advanced EMT or EMT level, likely at the advanced EMT level, we need to request a paramedic. Okay, when we bypass lakes, we need 3 providers. We need 1 person on the drive and we need 2 providers in the back. Okay, if you look at this asterisk here, we don't necessarily need a paramedic to bypass, but it is always relatively easy to get a paramedic. Okay, it doesn't have to be a Stewart's paramedic. It can be a firefighter from another department. But you should attempt to get a paramedic. If you do this to no avail, we can still bypass at the advanced EMT level if you have a conversation with medical control and tell them that you're at that level, okay? As long as you have another provider in the back. But we should always be trying to get a paramedic because they can do a lot more for these patients in the back than we can do, okay? We want to transmit our 12 leads to lakes and Concord Hospital, which we will be bypassing to. And we want to use LRGH as our med control, talk to the docs on the phone, and advise them of the bypass. Okay, does that make sense to everybody? This will be available on all the trucks, okay? And there will be some flow charts that we're reworking. Does anybody have questions about the bypass? Okay, and then if someone who works on Wolfboro side of the lake wants to comment on that bypass process a little more, Bob, maybe?
My understanding of the Wolfboro side is you need to have a good conversation with medical control, give them a good story, and just tell them you're headed for Wentworth Douglas or Frisbee. In the old days, they wanted you to come to Huggins first. That has kind of gone by the wayside now.
Okay, good. Is it still you need 2 providers in the back, just like the lakeside? Or are you able to bypass just with 1 paramedic?
Affirmative, you need 2.
Okay.
And the reason for that, if something goes bad, you don't want to have that all in your own hands. You want to have somebody to help you.
Good.
Janet texted me and said that for bypass, STEMI bypass on Wolfboro, you have to have a paramedic in the back. You cannot go without a paramedic.
Okay, so there's a difference between the Wolfboro side and the lake side right there. Okay, so we need a paramedic on that side of the lake. But regardless, you should be trying to get one, and pretty much 100% of the time, you'll be able to get a paramedic to bypass. Okay, EMTs, advanced EMTs, you have any questions about the bypass protocols? Otherwise, we're utilizing just our regular protocols for ACS. Nothing? Be very familiar with this because there's an acute possibility that you might be in charge of these type of patients.
Also, Zach, Concord Hospital, you don't
Mhm.
necessarily need to send a 12 lead to them, but at least notify them it was done, because now they can access it through their own system off of the rescue net.
Good. Okay, I like that. As long as you transmit it to lakes and notify them of the bypass. All right. So the last few slides, I believe I have this one and one more, and that's it, and then we're done. We're going to just go over again, when do we put the pads on the patient? Okay, this is an easy heuristic. So for EMTs and advanced EMTs, especially when you're alone, when do you place the pads on the patient? You want to place pads on patients who have bradycardic rhythms, who are symptomatic, as well as patients who are in VTAC, okay? It's unlikely that you'll see a patient, again, in VTAC with a pulse, but if you do, you'll want to place the pads on these patients. And again, routine patient care, establish IV access, get a 12 lead, and do not delay transport. So, important, where do we place the pads on these patients? Okay, because we don't want to inhibit our ability to take a 12 lead. So on these type of patients, whichever pad placement you're more familiar with, as long as you do not displace too many of the leads and you still have a proper vector on the heart, okay? These patients, you can do a AP placement of the pads. And if you do an AP placement of the pads, you're really only going to displace those septal leads, V1 and V2, okay? So as long as you're aware that you're going to have to do a 12 lead at one point, and you're still aware of the vectors of the shock, make sure that the shock is going through the heart. Those pads are actually placed so they're oriented that it goes through the heart. Then you'll be good, okay? So just be aware of that in these patients. So we place the pads on, obviously, patients in cardiac arrest right away, patients who are bradycardic who have any symptoms, and patients in VTAC, okay? And then this is our treatment, right? Call for the paramedic, and we do everything we normally do. Any questions or comments on that pad placement? Okay. Here's a big one, and this is the last one. We got to hit this home. When do we call for a paramedic? All right, so I gave you all these simple heuristics. Do this when that, do this when that. This one is not so simple, and I'm not going to provide you with a heuristic because we are all capable of determining when to call for a paramedic, okay? We are all clinicians, and we can all evaluate our patients using our fundamentalist understanding of anatomy and physiology and also pathophysiology, and be able to determine when we have to call for a paramedic. So I'm not going to tell you when this happens, call for a paramedic. You have to be a clinician, okay? We're all skilled enough to do that, right? The big patients that we're going to want to call for a paramedic are obviously the ones who have acute EKG changes, who have altered mental status, patients where we think we're going to need some ACLS interventions, okay? Because we can't do that at the AEMT or EMT level. All right. So remember your skills, or remember your anatomy and physiology. You all are capable of knowing when to call for a paramedic. All right. Any questions on that? I have profound confidence in all of you. And when in doubt, call for help. Okay. Don't get yourself into a pickle. Any questions on that? Any questions in general? How was the chat box? I really didn't see anything. Were there any pertinent questions we want to review, Evelyn, or anything?
No, I did a great job, buddy. You sound great.
Ah, thanks.
I don't know about the video thing. It really took some points off for me, though.
Yeah, it's okay. You have my slideshow. It's good enough.
All right. I'm glad it's on YouTube so I can review it later.
Regardless of
Like
all
I
these
said-
heuristics, if you think that maybe you should have done a 12 lead, do one. Nobody's ever going to fault you for doing one that you didn't need to do because it's only going to benefit you.
I agree with that. If you're riding to the hospital and you're thinking maybe I should have done one, do one. You got time. It's better than not doing one. I agree. Okay. What were there any questions that we should go over that were in the chat box, or is that it? Evelyn, you're muted.
I think it's the first time she's muted.
Hey, zip it. Sorry about that. I didn't realize when my kids came in that I wasn't muted. So Tim brought up a point that don't forget to mark your right-sided 12 leads that you're dropping off at the ED. I know you mentioned it when you were talking about your posterior ones. Bob had a question about Zoll's recommendations for limb lead placements for your 12 lead. And Zoll does recommend that if you can place your limb leads on the limbs, ankles and wrists, that's where you should attempt to place them. What else do we have here? Also making sure that you change the patient's age and sex because it defaults for, I think it's what, a 40-something-year-old male. And the computer, in order for diagnostically for it to be accurate, it needs to know the sex of the patient and the age. Also, Tim mentioned, don't forget your female diabetics because they're more apt to be having your silent MIs for 12 leads.
Good. I like it. ACS is not just substernal crushing chest pain.
And I think that pretty much covers stuff in the chat box, except they felt you should know the bypass protocols for Wolfboro because you spent a lot of time there.
That's a fact. That's a true story.
Was that Robin?
You go
Yeah,
fuck
it
yourself,
was.
Zach. It's just the truth, man. Trying to put the truth out there.
YouTubers out there watching this, not in the Zoom, make sure you go and do that vinyl course. It's a five question quiz and you get your Con Ed credit for it.
You sound like a YouTuber right now, Zachary.
That's how you also get registered for the course to get your CEUs. So please take the course.
Is Zach
Quiz.
Quiz, quiz.
It's
It's
just
a
a
quiz,
5
not a
question
course.
quiz. This was the course.
Zach? I was out saving lives. Could you start over?
Yeah, sure. Let me go back.
I
to the
missed that
slides.
first hour. I was actually drinking. So
Yeah, now